everyone. I'm Dr. Lahari here, and welcome to this chapter on salivary gland disorders. The learning outcomes would be to classify salivary gland diseases, explain the clinico-pathological aspects and management of obstructive and traumatic lesions of salivary glands, to explain the etiopathogenesis, clinical features, diagnostic workup, differential diagnosis, and management of Joplin syndrome. Now, the chapter is actually divided into a diagnosis aspect as well as a treatment aspect. I have covered few of the learning outcomes here, and the rest will be covered in the upcoming lectures. So let's just revise the anatomy of the salivary glands. We have three pairs of major salivary glands and numerous minor salivary glands. So the image that you can see here shows us the parotid gland location as well as the sublingual gland and the submaxillary, also called as a submandibular salivary gland. Now, apart from that, we have minor salivary glands that are distributed all over the oral mucosa, and these are ductless glands, and they're either serous, mucous, or mixed type of salivary glands. If you were to look at the classification of disorders of salivary glands, they can be divided based on their etiology into autoimmune conditions like Joplin syndrome or chronic graft versus host disease leading to disorders. Developmental disorders such as salivary gland aplasia, congenital fistulas in the duct system, or a Staphylococcus cyst, which we will see in the upcoming slides. Iatrogenic causes like radiation, post-surgical disorders of salivary gland, or a Botox injection leading to damage to the salivary glands. Inflammatory causes of diseases like Ig4 related diseases, also known as Kuttner's tumor or a Mucous disease. Infections causing infection of the gland due to viral conditions like cytomegalovirus, HIV, hepatitis C, or bacterial causing, for example, granulomatous diseases like tuberculosis affecting the salivary glands. Medication induced or medication associated disorders of the salivary gland caused by xerogenic drugs, neoplastic, benign and malignant tumors of the salivary glands, non-neoplastic conditions like silolithiasis, which are also obstructive disorders of the salivary gland, and systemic conditions like anorexia nervosa, diabetes mellitus, chronic alcoholism, or sarcoidosis that affect the salivary glands. Now we will look at some of the examples more commonly occurring diseases in this chapter. Let's look at the most common obstructive disease, silolithiasis. Silolithiasis means formation of stone in the salivary ducts. The contributing factors to what happens and why there is stone formation is primarily because of pooling of saliva, which leads to stone formation. So, generally, if there is inflammation or irregularities in the ductal system, or there are local irritants, or patient is on anticholinergic drugs, or a combination of all of these factors contributes to the pooling of saliva and stone formation. Generally, a salivary stone or a silolith, as it is called, has a composition of hydroxyapatite crystals, calcium phosphate, magnesium, and potassium, as well as chloride and ammonium ions. So, in patients with gout, the stones are generally made of uric acid. The most common location for a silolith is the submandibular salivary duct in around 80 to 90% of the cases, followed by the parotid or the sublingual salivary gland ducts. The higher rate of silolith formation in the submandibular salivary gland and its duct is primarily because of the tortuous course of the Warthin's duct. We understand that the location of the and the course of the Warthin's duct are responsible of stasis of saliva. Also, the higher content of calcium and phosphate levels in the saliva produced by the salivary gland and the position of the submandibular salivary gland itself. which is lower than its orifice of the duct, and hence there is a tendency for stasis of saliva within the gland and the duct itself, making it one of the most common salivary glands to have silolith formation. This is an image which shows you the location of the submandibular salivary gland. It's interesting to note that it is a J-shaped gland, part of which is located below the mylohyoid muscle and part of the gland is located above the mylohyoid muscle. So you can understand based on the anatomy and the location of the Wharton's duct that it actually has to pump its saliva and pour it against gravity higher up into the oral cavity. And hence there's a tendency for pooling of saliva in the lower part of the gland, making it a common location for stone formation. This is a picture which shows you a stone formation in the proximal part of the salivary gland duct. These are examples of how stones can look like. And this is a radiographic image of one of my cases which I had seen as a postgraduate, where you would, on a submandibular, on a occlusal view where the duct, the proximal part of the duct and its the siloliths within the duct are visible very clearly because of their radiopaque content. Now, it's important to understand that not all siloliths are crystalline or calcified enough to be visible on the radiograph as calcified structures. Sometimes the calcification process is not complete enough, and yet the silolith blocks the duct and blocking the release of saliva. Yet on the radiograph, you may not see the image of radio opaque silolith. But in this case, you can see in the occlusal radiograph that there are two siloliths in the salivary duct. Obviously, the duct is not visible because it is a soft tissue structure. So, when you're talking about diagnosis and treatment of siloliths, the clinical features of a patient would be acute, painful, intermittent swelling of the salivary gland due to obstruction and secondary infection. What happens is during eating, there is increased salivation. So, there is swelling of the gland because there is an obstruction and saliva cannot flow freely into the oral cavity. Bidigital palpation of the gland and the duct must be performed, and when it is done, sometimes the silolith can be easily diagnosed and its location can be made out clinically. On radiographs, like I just discussed, poorly calcified stones are not visible. So, plain radiography of a submandibular salivary gland in an occlusal view, or a parotid gland on an anterior posterior view, or a puff cheek posterior anterior view can show calcified stones, and they can be used. But to see them more clearly, a CT scan may be required, or siloendoscopy can be done, which is an endoscopic unit with a surgical tip that can help biopsy the gland or the duct, as well as remove the calcified material under local anesthesia within the ductal system itself. So this is an example of a silo endoscope which has a thin needle, and once a silolith is located, it can be identified by imaging, and the silolith can be actually broken down into pieces or removed with the help of a silo endoscopy, also silolithiasis. Next, let's move on to mucosal, which is an extravasation phenomenon and caused by trauma of the minor salivary glands. Now, it's very important to remember the common location for a mucosal is a lower lip, as shown in the images here. And this happens due to trauma, often because of biting of the area, and the salivary gland gets crushed, and these are the minor salivary glands, and you must remember that the minor salivary glands do not have ducts. This is an example of a superficial mucosal. We often have these tiny mucosals cropping up in the oral cavity, especially on the palate, when there is minor trauma, such as toothbrush related trauma, or even when you're eating sharp foods like chips or crisps, which can actually locally traumatize the mucosa, and the minor salivary gland actually gets traumatized, and there is extravasation of saliva into the adjacent mucosa, leading to a superficial mucosal. Often superficial mucosals rupture on their own and they subside. Another variant is a ranula, which is generally larger in size and seen in the floor of the mouth. And this is an example of a case with a plunging ranula, really large, leading to a large appearing swelling in the neck. So, when you're talking about treatment of mucosal and ranula, generally for mucosal, surgical excision is advised, followed by biopsy of the excised specimen, and this is done to prevent recurrence. So what happens is that the entire salivary gland, generally a minor salivary gland, and its surrounding areas are excised to avoid or prevent recurrence. Intralesional steroids have been tried, but their success is limited. In case of a ranula, surgical intervention is sort of, and also marsupialization and sublingual gland excision have also been suggested as treatment plans. Intralesional steroids have also been tried. Now, if you remember, the term ranula is actually derived from that of a frog's belly, because it looks like a frog's belly, and it's big, and it can sometimes enlarge at meal times and appear like a large swelling in the neck region. Moving on to necrotizing xylometaplasia, this is a benign self-limiting reactive inflammatory lesion of salivary gland tissue origin. Again, the minor salivary glands are affected, and it can appear like and can be confused for either a leukoplakic lesion or sometimes even a malignancy. But this is self-limiting and generally subsides within a period of 2 to 3 weeks. Next, moving on to silentinitis, the inflammation of the salivary gland is called as silentinitis. There are various causes of inflammation. It could happen because of allergic reactions, allergies such as drugs or pharmaceutical agents causing irritation to the gland and causing inflammation of the gland. Viral conditions, which are like mumps caused by paramyxovirus, cytomegalovirus, HIV, or hepatitis B. Bacterial infections, which could be the acute or chronic silentinitis, that is caused by aerobes such as Staphylococcus aureus, uh, Staphylococcus viridans, Haemophilus, or E. coli, and anaerobes like Prevotella, Porphyromonas, or Fusobacterium. Chronic sclerosing silentinitis is a condition which is also called as Kuttner's tumor. Generally, silentinitis can be painful if it is especially associated with bacterial or viral origin, and the person will exhibit fever. This is an example of a child with mumps, as you can see, is a common condition where the parotid is involved with paramyxovirus infection. Now, on the other hand, the pus discharge that is seen is generally classical of bacterial infection or bacterial silentinitis, and if it is parotitis, that is, the parotid gland is involved because of bacterial infection, then you can see pus discharge from the ductal system, and this is an example of pus discharge from the Stenson's duct. In the classification of salivary gland disorders, we've come to developmental disorders. One of the example is a Staphnase bone cavity. This is an appearance seen on the panoramic radiograph and could be an incidental finding. This should not be confused for a cyst, and it is not a true cyst. It is just a corticated defect in the posterior mandible below the inferior alveolar canal, and it may contain an extra part of the submandibular salivary gland. So, no treatment is offered, and generally, the patient is made aware of the condition, and it is left alone. Moving on to radiation induced pathology, head and neck cancers and radiation therapy in the head and neck region induces salivary gland destruction. A majority of the time, there is invariable involvement of the salivary gland, and radiation causes destruction of the salivary acini, leading to xerostomia, and the patient experiences viscous saliva. There is accompanying mucositis as well. And generally, absent salivary gland function, total absence, can happen after 6 to weeks or 6 to 7 weeks of radiation therapy, and permanent damage can occur at radiation amounts of 24 to 26 grays. Also, the patient could be accompanied by radiation caries. This is because of hyposalivation or the lack of saliva in the oral cavity. Um, Radiation induced salivary gland destruction can also increase the incidence of salivary gland neoplasms in these patients. So, it's important to prevent the damage caused by salivary gland destruction. It's important to actually use the 3D conformal CT scans with also radioprotective agents like emifostine, which can prevent the amount of damage that happens to the salivary glands during radiation therapy to the head and neck region. Like I told you, some amount of radiation invariably reaches the salivary gland due to the proximity of the cancer, depending on the proximity of the cancer and the area that is irradiated. But nevertheless, the gland can regenerate, and radioprotective agents like drugs like emifostine can help in a recovery of the gland and saving at least part of the gland for the patient. Systemic conditions with salivary gland involvement are numerous, but it's important to highlight the most important ones, that is diabetes mellitus, anorexia or bulimia, chronic alcoholism, dehydration, medication induced dysfunction, Mikulitz disease, Sjogren's syndrome, and granulomatous conditions like tuberculosis or sarcoidosis. I will not be going into the details of each and every disease, but just looking at some of the most important ones. So, when we're talking about salivary gland diseases, the most important disease that has to be mentioned is Sjogren's syndrome. This is a chronic autoimmune disease with oral and ocular dryness. Generally, there is exocrine dysfunction and destruction of the exocrine glands. Also, there is lymphocytic infiltration because it's an autoimmune condition. So, the etiology of Sjogren's syndrome is actually unknown and there is no cure that is found. So, Sjogren's syndrome can be classified as primary Sjogren's or secondary Sjogren's. Primary Sjogren's, there is lacrimal and salivary gland dysfunction and not really an autoimmune condition per se. Whereas in secondary Sjogren's syndrome, there is lacrimal gland, salivary gland dysfunction with an additional connective tissue disorder autoimmune condition like SLE, rheumatoid arthritis, scleroderma, or primary biliary cirrhosis in combination with the existing lacrimal and salivary gland dysfunction. So this is an example of a patient who has bilateral enlarged salivary glands, especially the parotid glands, prominently enlarged as a result of silentinitis that is seen in Sjogren's syndrome. Also, there is dryness of the oral mucosa and the tongue appears really dry and red. And this is a test to check the amount of tear ducts, the amount of tear produced or lacrimal gland function to assess the amount of tears that are produced. So, the most important or the most famous example that comes to mind when we're talking about Joplin syndrome in the recent years is Venus Williams, the famous tennis player. At the age of 31, she had to withdraw from major competition because she was diagnosed with autoimmune disorders, which caused her um, fatigue and joint pains, and which could have led to larger long-term problems. But she fought back and won the championship in the next couple of years to come, and was able to keep the disease in check. Like I told you, it's not possible to entirely cure the disease, but symptomatically manage it and keep it under control. It's important to remember that it's actually an autoimmune condition. The diagnostic criteria for diagnosing Sjogren's syndrome, the patient must exhibit four of the six mentioned criteria. A labial minor salivary gland biopsies, when done, should be positive for diagnostic or positive or diagnostic of Sjogren's syndrome, and that's one of the best diagnostic criteria. Presence of autoantibodies against anti-SSA or anti-Sjogren's syndrome A and anti-Sjogren's syndrome B. Ocular dryness, presence of oral dryness, reduction in lacrimal function measure, salivary function and quality also are reduced, and imaging through xylography, CT scan, or MRI showing classical features of or diagnostic features of Sjogren syndrome. On xylography, imaging of the salivary gland done with the help of a retrograde dye injection into the salivary duct. The classical image that is seen in cases of Sjogren syndrome is a branchless, fruit laden tree appearance or a cherry blossom appearance. Now, this is some a very important clinical or radiographic features that is important to remember and associated with Sjogren's. This happens because of stasis of the dye within the salivary parenchyma, and not enough salivary production to actually eliminate the dye. So this indicates that there is stasis of the dye within the salivary parenchyma, and an indication of silentitis and Sjogren syndrome. So similar appearance seen on the CT scan as well, which shows you these radio opaque or opacified areas of stasis of the dye, and which is called as silentasis, classical feature of Sjogren syndrome. The treatment of Sjogren syndrome is relies on symptomatic relief and also disease modifying drugs. Generally, steroids, that is glucocorticoids, immune suppressants, antimalarials, and biological agents like tumor necrosis factor or interferon alpha have been used to help with the disease. And the treatment of xerostomia is also important, done with the help of artificial saliva, oral rinses, and water sipping. Stem cell replacement therapy has been tried for salivary hyperfunction, and it should be noted that there is increased incidence of malignant lymphoma in Sjogren syndrome, and hence these patients need to be under regular follow-up. So that's it from me for this chapter. There will be continuation of the remaining part of this chapter in the second lecture that is to come. Thank you, and if you do have any doubts, please feel free to write to me.